Hello, ABMP Podcast listeners. It's Kristen, ABMP's Director of Professional Education, inviting you to join us at the ABMP CE Summit Aging Clients on Tuesday, May 12th. This online event, including 3 hours of CE, is free for everyone in the profession and features courses from instructors Ruth Werner, Sheila Alexander, and Dawn Castiglione. Learn how the body changes over time, common age-related pathologies, and practical hands-on techniques for working confidently with senior clients from active to medically complex. Register today at abmp.com/summit. See you online. Stop straining your hands and start getting your clients underfoot. At the Center for Barefoot Massage, we teach you to use gravity and physics to deliver effortless, deep myofascial work. Through our fasci-ashi approach of myofascial ashiatsu, barefoot mat work, and stretch therapy, you'll learn evidence-based techniques to resolve persistent pain. Worried about your size difference in relation to clients? Our innovative Ashi strap supports therapists of all builds to vary pressure with precision. The future of massage is afoot. Discover our upcoming CE classes at centerforbarefootmassage.com.
Hi everyone, I'm Whitney Lowe and welcome to the ABMP Podcast, a podcast that speaks to the massage and bodywork community. Today, I'm honored to be your guest host, and as many of you know, I am the director of the Academy of Clinical Massage, where I've spent the last, about 4 decades or so exploring how we can use evidence-based research and clinical experience to help our clients find relief from pain and injury. So today, we're going to be doing a sort of interesting deep dive into some new findings about shoulder pain that may perhaps even radically change the way that we approach this condition with our clients. So let's take a look and see what we can explore. One of the most significant findings that we've seen from coming out of research about shoulder pain in the last decade or two is really kind of a radical rethinking of what's going on with the majority of shoulder pain complaints. Shoulder pain is exceedingly common, especially when we talk about something called subacromial impingement syndrome, or SAIS, which is now sort of being changed to the terminology being preferred as subacromial pain syndrome. But this does tend to account for about 44 to 65% of shoulder consultations. So it's a whole lot of people out there having this particular type of problem. But the big shift has been sort of a move away from a more mechanical focus on what's called impingement, which was the idea that structures, especially soft tissue structures, were getting pinched underneath a bony archway called the coracoacromial arch. And now we're moving towards more of a kind of an umbrella term of subacromial pain syndrome, or it's also sometimes called rotator cuff related shoulder pain, that has a much more complex understanding of the neurophysiology and biomechanics involved in this condition, and not just a simple idea of something's getting squeezed because there's not a whole lot of space in there. So we're going to take this newer understanding and explore what this might mean for how we address shoulder problems. One of the more interesting things that has been driving this sort of change to narrative and shifting understanding about shoulder pathology is some long-term follow-up from several surgery or research studies involving shoulder surgery, where people who had been diagnosed with subacromial pain syndrome or subacromial impingement went in and they were divided up into different groups. One group getting the standard arthroscopic surgical procedure, which was called an acromioplasty, where they go in and shave off the underside of the acromion process, where there are often bone spurs that develop, and they're trying to shave that bone spur off to make more room so that it's not squeezing on those soft tissues. Then another group was given exercise routine to do, no surgery, just exercise. And a third group was given sham surgery, which is an odd concept, but basically what it means is they made a surgical incision, put the arthroscope in there just like they would during a regular surgical procedure, and then flushed it with some saline solution, so there was some discomfort and a little bit of pain afterwards, just like it would have been under a regular surgery. And then they followed these people for a significant period of time. Look at the follow-up at 6 months and 1 year and 5 years and 10 years. And the findings were really quite remarkable. They found that the people in the surgical group and the people in the exercise group had very little, if any, significant differences between the groups in terms of their outcomes for pain management and the reduction of pain symptoms at the long-term follow-up. What was the most surprising was the people in the sham surgery group also had those same degree of improvements. So the surgical procedure itself, it seems, may not really have even been the primary thing that made a lot of those people better, because the people with the sham surgery who didn't even get a surgical procedure where they shaved off the acromion, they still got better as well at the same rate. So this makes us really rethink what actually is going on there, and also rethink a lot of what happens during certain types of treatments. So let's take a deep dive in and see if we can explore a little bit more about why this has changed, what's happening here, and what subacromial pain is all about. So the first place for us to start is looking at the anatomical structures that we're dealing with here. So again, this is a podcast, so we can't really show pictures and images, but knowing your anatomy, you can follow along here. So remember, we have the acromion process, which is like a shelf at the top of the shoulder region, and the coracoid process, which is a small bony projection about the size of your pinky finger that projects out a little bit toward the front side of your shoulder. In between those two bony prominences is a dense fibrous ligament called the coracoacromial ligament. And if you include the coracoid process, that ligament, and the acromion process, this is a curved area that we call the coracoacromial arch. And then we have, unfortunately, quite a number of soft tissues underneath the coracoacromial arch that can potentially get compressed or pinched under there, such as the subacromial bursa, the supraspinatus tendon, the tendon from the long head of the biceps brachii, the upper margins of the joint capsule, even the subscapularis tendon on the upper portions of that tendon can get compressed underneath this coracoacromial arch. We see most of those problems in the far end or the far range of forward flexion and abduction out to the side. That's when those structures get most likely, that's when they're most likely to get compressed or pinched underneath that coracoacromial arch. Now, when those structures do get compressed underneath there, this can lead to all kinds of dysfunction or problems in those tissues. It can lead to actual fiber tearing of the supraspinatus tendon. It can lead to ischemia, lack of blood flow. It can lead to sort of inflammatory reactions in the subacromial bursa. But back up for a moment, and just one of the things that's interesting about some of the MRI studies that have been done about shoulder problems have found, because now what they've done with the MRI is tracking a lot of people who don't have any problem or any pain complaint at all, and looking at what's happening with their structure. And what we find is there's a whole bunch of people out there who have really torn up rotator cuff tendons and supraspinatus damage and bone spurs and all this kind of stuff, and no pain whatsoever. So that makes us really rethink, what is the mechanism that's making, one person's shoulder that just looks really trashed on imaging studies have no pain, and somebody else who goes in and has a shoulder imaging study that doesn't look, it looks pretty unremarkable, nothing significant in there, but they can't even begin to lift their hand over their head because the shoulder pain is so significant. So that means we got to rethink, what is at the root of all this kind of stuff, and that's what we're going to take a look at here. So again, just to rewind for a moment, reminding ourselves some of the key players in here that we were going to focus on: the supraspinatus tendon, and especially the distal end of that supraspinatus tendon, because the area at the end of it is called the critical zone, and this is an area with very poor blood supply, so it doesn't have as great a capability to regenerate and repair itself when it is potentially damaged. The subdeltoid or subacromial bursa, which are in this region as well, these are highly vascularized and richly innervated sources of pain, because that bursa is super sensitive. And now we're also finding out that this bursa is not just a little cushioned sac filled with fluid. There's a whole lot of chemical activity inside that bursa, and sometimes compression and irritation of that bursa may cause some of these highly sensitizing chemicals to be leaked out of that bursa into the subacromial space, and that's a significant driver of shoulder pain. We also know that the long head of the biceps travels up and make a right angle turn right underneath that coracoacromial arch just where it attaches to the top of the glenoid fossa. So this is another tissue potentially in the region there that could be very damaged from the overload of forward flexion and abduction. I mentioned earlier that some people develop bone spurs on the underside of the acromion process. This has been known for quite some time, and this was sort of the reason that a lot of people went in and got shoulder surgery. But now we're recognizing that the presence of that bone spur doesn't always correlate with pain, because there's a lot of situations where people have very significant bone spurs and no clinical pain. So we're going to try to look at what is the physiology and the pathophysiology causing the pain complaints in there. So let's take a deep dive and look in and see what's happening there in the shoulder. Now, one of the things that we do know that happens to tendon tissue from repetitive compressive loading, and this is what is happening when it's getting squeezed or pinched periodically underneath that coracoacromial arch, is you begin to get collagen degeneration in that tendon. And as a result of the repeated pressure and compression forces on the underside of that acromion process, the collagen begins to degenerate, and this also causes something called neovascularization, which is a whole bunch of new blood vessels coming into that area. Now, anytime you have tendon degeneration and neovascularization, which actually happens not only in the rotator cuff tendons, but all of your chronic tendon disorders in different parts of the body have the same process. What we know now is that with this neovascularization, there is an extensive group of small sensory fibers that also develop right alongside these new blood vessels. So that's one of the primary reasons that tendon disorders hurt. It's not because of inflammation or torn tendon fibers that we used to think in the older days when we were looking at tendonitis complaints. We now understand that many of the reasons that people feel pain with these chronic overuse tendon disorders is much more associated with the neovascularization and the excess sensory cells that are in there that are causing that to be painful. Now, the next step we want to look at is another facet of this, which is we mentioned that when there are chronic degenerative processes in the tendons, and this is also true when there's compression on the bursa, and sometimes the bursa may get a little bit damaged, that causes a lot of chemical irritants in the shoulder region. And this is a good explanation for why many people might have significant pain in their shoulder and no apparent compression or damage to the soft tissues. The damage that's causing the leakage of all of these sensitizing chemicals is not significant enough to really show up on many of these imaging studies, but it is definitely enough to irritate the sensory nerve endings in the area and cause significant shoulder pain. So sometimes that's why one person has shoulder pain and another person doesn't. There's all kinds of factors that may play into this. But it also, again, we're going to talk about this in a little bit more detail in a moment. This helps change a lot of what we're looking at for how we're going to treat these areas too, because formerly we were under the assumption that this was a compression problem with chronic tendon irritation, and we would go in with deep transverse friction trying to manage scar tissue and manage an inflammation of the tendon right underneath that coracoacromial arch. And that actually not only might be maybe not a great idea, it could actually be potentially damaging for this problem depending on the nature of what's really driving the primary pain for the client.
Let's take a short break to hear a word from our sponsors. At Heights Retreats, massage therapists build stable and meaningful careers rooted in wellness and care. A place where therapists are dedicated to delivering exceptional care to the guests, not to filling their schedule. Heights Retreats care deeply about their therapists, our profession, and wellness itself. Grow with Heights as they evolve into a wellness-driven future. Visit heightswellnessretreat.com for more information. Elevate your bodywork career with Anatomy Train's Structural Integration Certification, ATSI. Discover how to map the pattern and shape the change through inspiring lectures, hands-on body reading, and practical techniques you can use in your practice right away. Join us for ATSI Maine 2026 to 2027, where Tom Myers will personally kick off this transformative professional training. Learn more at anatomytrains.com/ATSI. Let's get back to our conversation.
Now, the next step I want to go along is recapping something that I've spoken about in a previous episode, and I think several of the other hosts on the podcast have talked about as well too. And this is the difference between nociceptive pain and nociplastic pain. So nociceptive pain is that pain that is most commonly associated with some type of tissue damage where you can identify some structure that has been exposed to excessive compressive or tensile forces and caused an irritation. And sometimes there may be chemical irritation along with the mechanical irritation of those tissues, but there is clearly some type of disruption to those tissues that is driving those sensations. Now, if that pain persists for a long period of time and does not get resolved, this may eventually morph into something called nociplastic pain. And nociplastic pain is a pain process or a type of pain where this is not really being driven by tissue damage any longer. It's being driven by an excess sensitivity in the nervous system. So what happens is the longer that pain process goes on and the more it gets irritated, the more it tends to spill over and sort of irritate other portions of the central nervous system. And you begin to get what's called central sensitization, which is an increased degree of sensitivity of the entire nervous system. And these clients may sometimes display characteristics called hyperalgesia, which is extreme sensitivity. And so you might, touch them with something that you don't think is necessarily a really hard pressure. And they say like, it's way too much. It really hurts. Or on the far end of that spectrum is something called allodynia, where something that should not be painful at all is painful for a person, just like maybe, rubbing a wool sweater across their skin or something like that can really hurt because that has irritated those nerve endings so significantly. So this process of nociplastic pain is one of the things that causes those significant shoulder complaints in there. And this is not a mechanical problem that we want to go in and try to mechanically do something to, like friction massage, or we're not trying to mobilize scar tissue or stretch adhesions or anything like that. We've got to deal with the nervous system if this is a nociceptive pain complaint. And one of the best ways to do that is just with soothing, gentle, comforting massage. And it's a little bit challenging sometimes to explain to people why this general soothing massage is so good and so beneficial for them, because they think you need to get in there and dig it out. And that's just not the thing that needs to happen. Because if somebody has a nociplastic pain complaint, which has sensitized their nervous system, and you go in and dig really hard and deep in there, you will flare that up even further and make the condition worse. And that's definitely not something that we want to be doing. So how do we tell the difference between a nociceptive pain problem and a nociplastic pain problem? There are a couple of key indicators that can help us in the assessment process. So first of all, with nociplastic pain, you tend to see patterns of pain and discomfort that don't necessarily follow a really good guideline. Like sometimes they'll just say, well, everything hurts. Every movement I do, everything I do with my shoulder hurts. All these different positions hurt. And sometimes it's, pain when they're doing very little activity at all. Whereas with nociceptive pain, which is really still associated with some type of tissue injury or tissue damage, there is usually a strong correlation with a particular pattern of discomfort, like the active and passive movements at the far end of forward flexion and far end of abduction are where the pain is most significant. A lot of times we'll see something called a painful arc, where there is significant pain in the shoulder when they're doing abduction between about 70 and 120 degrees of abduction. But then after 120 degrees, if they keep going all the way up, the pain reduces or even completely goes away. And this has to do with some of these tissues getting compressed as you raise the shoulder up, and then they're basically scooting underneath that acromial process as it go into the very end of those abduction movements. So those indicators, especially if there's specific movement-oriented things that stress the potential tissues that you think might be involved, those are some of the best indicators to determine that we've got a nociceptive and not a nociplastic pain problem. Now, one of the other things we want to be really careful about are clinical red flags, or these are important things that we want to make sure we don't just gloss over, because there can be some really serious complaints in there that act like rotator cuff problems or act like subacromial impingement that really aren't. So if your client reports unremitting night pain, so pain that's especially at night or any time, and it doesn't have anything to do with movement, it just seems to be constantly painful in all different kinds of position. This is something that could be some type of visceral problem, especially if there's pain referred to the left shoulder. We see a lot of times pain in the left shoulder associated by viscerosomatic reflexes from the spleen, for example. And what's happening is the sensory fibers from abdominal organs are joining into the spinal cord at the same level as some of these sensory fibers from the tissues of the shoulder region. And your brain has a hard time telling which one of these things is really the problem here because they're all reporting at the same spinal level. So an irritation in those organs can sometimes mimic shoulder pain and seem like it is a shoulder problem, and we can massage that shoulder all day, and very likely the pain's not going to get reduced because there is some other type of organ system problem going on. So here's a couple of quick things to think about with making that distinction between musculoskeletal disorders and some type of organ system like spleen problems. So note that with musculoskeletal shoulder pain, it's often deep in the joint or at the insertion of some of those particularly irritated tissues. And you can usually palpate those tissues and make the pain be somewhat increased at that point. So with the referred pain from organ dysfunctions, oftentimes they're sort of at the tip of the shoulder, especially again like the left shoulder from spleen injuries and things like that. Usually up near the top of the left shoulder is where that's felt. When you do various types of resisted testing, like resisted abduction or resisted forward flexion movements, that usually reproduces the pain for a musculoskeletal disorder. That will have very little effect on the organ system problem, but they might have problems with things like deep breathing or lying with the head down, anything in the certain positions that might be not necessarily involving shoulder mechanics, but involving movement of the diaphragm and movement of the other organ systems. Those things could be aggravating for the systemic organ system problems. So also remember the history is critically important. Find out if there's things in that history that indicate overuse or possible strain of the shoulder musculoskeletally and mechanically. That would be an indicator of potential shoulder subacromial pain problems. If there's a history of recent abdominal trauma or systemic illness or systemic inflammation, those are things that would be red flags for looking for organ system problems. And again, we mentioned palpation because tenderness directly over the tendons or the bursa where you can press right on them oftentimes is a good indicator of a musculoskeletal disorder versus no tenderness right at the shoulder, but you might have some tenderness in the abdomen. If somebody palpates the abdomen a little bit, there will be tenderness in there as well. So how does this aim and shift and change what we do with our treatment? So keep in mind that we've got sort of some shifting goals now from the things that we used to do, like the ideas that we were breaking down scar tissue or we were trying to, realign torn tendon fibers or things like that. Now we're focusing more on the sort of peripheral musculoskeletal reactions like mechanical trigger points that develop in these muscles that cause the scapular mechanics to be altered very significantly. So working on these muscles to reduce hypertonicity and myofascial trigger points and get shoulder biomechanics reestablished is critically important. There are some numerous key muscles here in addition to the rotator cuff muscles that we need to focus on. The role of the serratus anterior in helping to manage shoulder position. The mid and upper trapezius also play a coordinating role with the serratus anterior. The pectoralis minor muscle can pull the shoulder girdle in an anterior direction and cause dysfunctional shoulder mechanics. And all of these things can contribute to making that subacromial space smaller and then potentially irritating and aggravating those structures. So that's all critically important. It's also really important that we're doing some movement activities with the shoulder at the same time that we're doing some of the massage techniques, because what we know now too about the gait control theory of pain indicates the more that we can enhance sensory information coming into the central nervous system, like the touch from our movement, the gliding of our hand on the skin, and the actual movement of the arm or shoulder region itself, all gives a barrage of multiple sensory and proprioceptive signals into the central nervous system, and they outpace those nociceptive signals and can be very beneficial in pain management. We also know that a lot of as we mentioned earlier, just even things like the very general massage and the caring, compassionate way that you touch and interact with your client can have super powerful effects on the release of endogenous opioids and also indicating and stimulating a process we call descending modulation, which is helping the nervous system sort of turn down the volume of irritants of what it's sensing in shoulder pain. So you don't have to get super fancy with lots of different types of techniques, lots of just gentle, compassionate, caring work around the shoulder that helps sort of normalize shoulder mechanics and decrease myofascial trigger point activity. And also some of the shear force that we apply to these shoulder tissues where we're sort of gliding across the skin or even pulling on the skin with skin dragging techniques like myofascial release or what's sometimes called dermoneuromodulation. Those methods have very beneficial effects in stimulating the fasciocytes to release hyaluronan and encourage increased slide and glide between adjacent tissue layers. So these are all critical benefits from what massage can do. And despite the fact that we've changed our image and understanding of a lot of what's happening here with shoulder pain, one of the things that I find so exciting and interesting about this is it's given us even more reason to understand the beneficial effects of what we can do with massage to address these particular types of problems. Because, a person may go in and be given a prescription for an exercise regimen with physical therapy, which can be beneficial in addressing that shoulder pain. But if they don't address the tissue tightness and dysfunction in some of those tissues before starting the exercise, they may further aggravate some of those existing neurological pain problems. So the massage is a great way to help sort of clean the slate and get those tissues prepared for the level of conditioning that they need to be engaging in their physical therapy practice. And that's another way in which what we do works so well with some of these other professions. So hopefully this exploration of shoulder pain and what we're now learning about the biomechanics and pain science and neurophysiology can help you guide some more effective massage treatments with your clients and help that vast number of people out there with shoulder pain who may be seeking your help because you can change their lives. So thanks again for listening. This is Whitney Lowe, and I look forward to seeing you again on another episode of the ABMP Podcast.
Precision Neuromuscular Therapy has been teaching high-quality seminars for over 20 years across the country. Founded by Doug Nelson, PNMT uses problem-solving skills and precise treatment options to get powerful results for your clients. PNMT seminars focus on honing your assessment and palpation skills to precisely target the source of your client's pain while understanding the why behind the what. Meet us in a hands-on seminar or online in the PNMT portal and let us join you on your learning journey. Learn more at pnmt.org.